Acute pancreatitis. This lecture focuses on the recognition and management of acute pancreatitis. Pancreatitis is an inflammatory process in which pancreatic enzymes autodigest the gland. The gland sometimes heals without any impairment of function or any morphologic changes. This process is known as acute pancreatitis. Pancreatitis can also occur intermittently, contributing to the functional and morphologic loss of the gland. Recurrent attacks are referred to as chronic pancreatitis. Both forms of pancreatitis may present in the emergency department with acute clinical findings. Recognizing patients with severe acute pancreatitis as soon as possible is critical for achieving optimal outcomes. Once a working diagnosis of acute pancreatitis is reached, lab tests are obtained to support the clinical impression, to help define the etiology, and to look for complications. Diagnostic imaging is unnecessary in most cases, but may be obtained when the diagnosis is in doubt, when severe pancreatitis is present, or when an imaging study might provide specific information needed to answer a clinical question. Image-guided aspiration may be useful. Genetic testing may be considered. Management depends largely on the severity. Medical treatment of mild acute pancreatitis is relatively straightforward. Treatment of severe acute pancreatitis involves intensive care. The goals of medical management are to provide aggressive supportive care, to decrease inflammation, to limit infection or superinfection, and to identify and treat complications as appropriate. Surgical intervention, open or minimally invasive, is indicated in selected cases. That was the background for this lecture. Here on this picture, you can see severe pancreatitis with areas of necrosis, hemorrhages, which is typical for severe necrotizing pancreatitis. So let's start with the epidemiology. Worldwide, the incidence of acute pancreatitis ranges between 5 and 80 per 100,000 population, with the highest incidence recorded in the United States and Finland. For example, in Lüneburg, Germany, the incidence is about 18 cases per 100,000 people. In Finland, it's more than 70 cases. Similar incidence rates have been reported in Austria. The incidence of disease outside North America, Europe, and Australia is less well known. In Europe and other developed nations such as Hong Kong, for example, more patients tend to have gallstone pancreatitis, whereas in the United States, alcoholic pancreatitis is most common. As for the age-related demographics, the median age on onset depends on the etiology. The following are median ages of onset of various etiologies. Alcohol-related 39 years, biliary-related 68 years, trauma-related 66 years, drug-induced etiology 42 years, ERCP-related 58 years, and AIDS-related 31 years. Hospitalization rates increase with age. For people aged 35 to 75 years, the rate doubles for males and quadruples for females. As for the sex-related demographics, generally acute pancreatitis affects males more often than females. In males, the etiology is more often related to alcohol. In females, it is more often related to biliary tract disease. Idiopathic pancreatitis has no clear predilection for either sex. Race-related demographics. The hospitalization rates of patients with acute pancreatitis are 3 times higher for African Americans than for whites. These racial differences are more pronounced for males than females. The risk for African Americans aged 35 to 64 years is 10 times higher than for any other group. Prognosis. So we'll start from etiology. Long-standing alcohol consumption and biliary stone disease cause most cases of acute pancreatitis, but numerous other etiologies are known. In up to 30% of cases, the cause is unknown, though studies have suggested that as many as 70% of cases of idiopathic pancreatitis are secondary to biliary lithiasis. Biliary tract disease, one of the most common causes of acute pancreatitis in most developed countries, accounting for approximately 40% of cases. And this cause is gallstones passing into the bile duct and temporarily lodging at the sphincter of Oddi. The risk of a stone causing pancreatitis is inversely proportional to its size. It is thought that acinar cell injury occurs secondary to increasing pancreatic duct pressures caused by obstructive biliary stone at the ampulla of Vater, although this has not been definitely proven in humans. Occult microlithiasis is probably responsible for most cases of idiopathic acute pancreatitis. Alcohol use is major cause of acute pancreatitis, accounting for at least 35% of cases. At the cellular level, ethanol leads to extra intracellular accumulation of digestive enzymes and their premature activation and release. At the ductal level, it increases the permeability of ductules, allowing enzymes to reach the parenchyma and cause pancreatic damage. Ethanol increases the protein content of pancreatic juice and decreases bicarbonate levels and trypsin inhibitor concentrations. This leads to the formation of protein plugs that block pancreatic outflow. Most commonly, the disease develops in patients whose alcohol ingestion is habitual over 5 to 15 years. Alcoholics are usually admitted with acute exacerbation of chronic pancreatitis. Occasionally, however, pancreatitis can develop in a patient with a weekend binging habit, and several case reports have described a sole large alcohol load precipitating the first attack. Nevertheless, the alcoholic who imbibes routinely remains the rule rather than the exception for the development of pancreatitis. Currently, there is no universally accepted explanation for why certain alcoholics are more predisposed to developing acute pancreatitis than other alcoholics who ingest similar quantities. ERCP. Pancreatitis occurring after endoscopic retrograde cholangiopancreatography is probably the third most common type, accounting for approximately 4% of cases. Whereas retrospective surveys indicate that the risk is only 1%, prospective studies have shown the risk to be at least 5%. The risk of post-ERCP acute pancreatitis is increased if the endoscopist is inexperienced. If a patient is thought to have sphincter of Oddi dysfunction, or if manometry is performed on the sphincter of Oddi. Aggressive intervention intravenous hydration has been durably shown to prevent post-ERCP pancreatitis in randomized studies. More recently, rectal endomethacin has been employed. It has been shown to reduce the incidence of post-ERCP pancreatitis and is now widely accepted at most institutions. The literature continues to debate the role of rectal endomethacin. Trauma. Abdominal trauma, approximately 1.5%, causes an elevation of amylase and lipase levels in 17% of cases and clinical pancreatitis in 5% of cases. Pancreatic injury occurs more often in penetrating injuries, for example from knives, bullets, than in blunt abdominal trauma, for example from steering wheel, horses, bicycles. Blunt injury to the abdomen or back may crush the gland across the spine, leading to a ductal injury. As for the drugs, considering the small number of patients who develop pancreatitis compared to the relatively large number who have received potentially toxic drugs, drug-induced pancreatitis is a relatively rare occurrence, accounting for approximately just less than 2% of cases. That is probably related to an unknown predisposition. Fortunately, drug-induced pancreatitis is usually mild. There are two groups: definitely associated drugs and drugs probably associated with acute pancreatitis. So, among definitely associated with acute pancreatitis drugs are azathioprine, sulfonylamides, tetracycline, valproic acid, methyl-dopa, estrogens, furosemide, pentamidine, octreotide. In addition, there are many drugs that have been reported to cause acute pancreatitis in isolated or sporadic cases. And the last group of etiological factors, there would be less common causes, and the following causes each account for less than 1% of cases. Infection. Several infectious diseases may cause pancreatitis, especially in children. These cases of acute pancreatitis tend to be milder than cases of acute biliary and alcohol-induced pancreatitis. Viral causes include mumps virus, cytomegalovirus, hepatitis virus, Epstein-Barr, Salmonella, Campylobacter, and Mycobacterium tuberculosis. Worldwide, a scarce is recognized cause of pancreatitis resulting from the migration of worms and in and out of the duodenal papilla. Pancreatitis has been associated with AIDS. However, this may be the result of opportunistic infections, neoplasms, lipodystrophy, or drug therapies. Hereditary pancreatitis. Hereditary pancreatitis is an autosomal dominant gain-of-function disorder related to mutations of the cationic trypsinogen gene. In addition, such mutation plays a role in predisposing patients to acute pancreatitis by causing abnormalities of ductal secretion. At present, however, the phenotypic variability of patients with such a mutation is not well understood. Certainly, patients homozygous for the CFTR mutation are at risk for pancreatic disease, but it isn't yet clear which of more than 800 mutation carries the most significant risk. Hypercalcemia. Hypercalcemia from any cause can lead to acute pancreatitis. Causes include hyperparathyroidism, excessive doses of vitamin D, familial hypocalciuric hypocalcemia, and total parenteral nutrition. Routine use of automated serum chemistries has allowed earlier detection and reduced the frequency of hypercalcemia manifesting as pancreatitis. Developmental abnormalities of pancreas. The pancreas develops from two buds stemming from the alimentary tract of the developing embryo. There are two developmental abnormalities commonly associated with pancreatitis: pancreas divisum and annular pancreas. Pancreas divisum is a failure of the dorsal and ventral pancreatic ducts to fuse during embryogenesis, probably a variant of normal anatomy. It occurs in approximately 5% of the population. In most cases, it may actually protect against gallstone pancreatitis. It appears that the presence of stenotic minor papilla and an atretic duct of Santorini are additional risk factors that together contribute to the development of acute pancreatitis through an obstructive mechanism, although this is controversial. Pancreas divisum associated with minor papillostenosis causing recurrent pancreatitis. Here are the main etiologies: alcohol, biliary disorders, idiopathic, and less than 1% for each any other. Alright, now we're gonna move probably to pathophysiology. Pathophysiology, let's stop for a bit of normal pancreatic function to understand the whole pathophysiology process. So, the pancreas is a gland located in the upper posterior abdomen, and it is responsible for insulin production, that's endocrine pancreas, and the manufacture and secretion of digestive enzymes, that's exocrine pancreas, leading to carbohydrate, fat, and protein metabolism. Approximately 80% of the gross weight of the pancreas supports exocrine function, and the remaining 20 is involved with endocrine function. The focus of this article, of this lecture, is on the exocrine function of the pancreas. The pancreas includes and accounts for only 0.1% of total body weight, but has 13 times the protein producing capacity of liver and reticuloendothelial system combined, which together make up 4 of total body weight percent. Digestive enzymes are produced with the pancreatic acinar cells packaged into the storage vesicles called zymogens and then released via the pancreatic ductal cells into pancreatic duct, where they are secreted into a small intestine to begin the metabolic process. In normal pancreatic function, up to 15 types of digestive enzymes are manufactured in the rough endoplasmic reticulum, targeted in the Golgi apparatus and packaged into zymogens as proenzymes. When a meal is ingested, the vagal nerves, vasoactive intestinal polypeptide, gastrin-releasing peptide, secretin, cholecystokinin, and encephalin stimulate release of these proenzymes into the pancreatic duct. The proenzymes travel to the brush border of the duodenum, where trypsinogen, the proenzyme for trypsin, is activated via hydrolysis of an N-terminal hapsopeptide fragment by the brush border enzyme enterokinase. Trypsin then facilitates the conversion of other proenzymes into their active forms. A feedback mechanism exists to limit pancreatic enzyme activation after appropriate metabolism has occurred. It is hypothesized that elevated levels of trypsin, having become unbound from digesting food, lead to the decreased CCK and secretin levels, thus limiting further pancreatic secretion. Because premature activation of pancreatic enzymes within the pancreas leads to organ injury and pancreatitis, several mechanisms exist to limit this occurrence. First, proteins are translated into the inactive proenzymes. Later, post-transitional modification of the Golgi cells allow their segregation into the unique subcellular zymogen compartments. The proenzymes are packaged in a paracrystalline arrangement with protease inhibitors, and zymogen granules have the acidic pH and a low calcium concentration, which are factors that guard against premature activation until after secretion has occurred, and extracellular factors have triggered the activation cascade. Under various conditions, disruption of these protective mechanisms may occur, resulting in intracellular enzyme activation and pancreatic autodigestion, leading to acute pancreatitis. Now, we're going to talk about the pathogenesis of acute pancreatitis. Acute pancreatitis may occur when factors involved in maintaining cellular homeostasis are out of balance. The initiation event may be anything that injures acinar cells and impairs the secretion of zymogen granules. Examples include alcohol use, gallstones, and certain drugs. At present, it is unclear what physiological event triggers the onset of acute pancreatitis. It is believed, however, that both extracellular factors, neural vascular response, and intracellular factors, example grazie intracellular digestive enzyme activation, increased calcium signaling, and heat shock protein activation play a role. In addition, acute pancreatitis can develop when ductal cell injury leads to delayed or absent enzymatic secretion, as seen in patients with CFTR gene mutation. Once a cellular injury pattern has been initiated, cellular membrane trafficking becomes chaotic with the following deleterious effects. Lysosomal and zymogen granule compartments fuse, enabling activation of trypsinogen to trypsin. Intracellular trypsin triggers the entire zymogen activation cascade. Secretory vesicles are extruded across the basolateral membrane into the interstitium, where molecular fragments act as hemoattractants for inflammatory cells. Activated neutrophils then exacerbate the problem by releasing superoxide, the respiratory burst of proteolytic enzymes, cathepsins, B, D, and G, collagenase, and elastase. Finally, macrophages release cytokines that further mediate local and, in severe cases, systemic inflammatory responses. The early mediators defined to date are tumor necrosis factor alpha, interleukin 6, and interleukin 8. These mediators of inflammation cause an increased pancreatic vascular permeability, leading to hemorrhage, edema, and eventually pancreatic necrosis. As the mediators are excreted into the circulation, systemic complications can arise, such as bacteremia due to gut flora translocation, acute respiratory distress syndrome, pleural effusions, GI hemorrhages, and renal failure. The systemic inflammatory response syndrome, SIRS, can also develop, leading to the development of systemic shock. Eventually, the mediators of inflammation can become so overwhelming that hemodynamic instability and death ensue. In acute pancreatitis, parenchymal edema and pancreatic fat necrosis occur first. This is known as acute edematous pancreatitis. When necrosis involves the parenchyma accompanied by hemorrhage and dysfunction of the gland, the inflammation evolves into hemorrhagic or necrotizing pancreatitis. Pseudocysts and pancreatic abscesses can result from necrotizing pancreatitis because enzymes can be walled off by granulation tissue or via bacterial seeding of pancreatic and peripancreatic tissue. That's the formation of pancreatic abscess. It was compared two sets of patients with severe acute pancreatitis, one with acute renal failure and other without it, and it was determined that a history of renal disease, hypoxemia, and abnormal compartment syndrome were significant risk factors for acute renal failure in patients with severe acute pancreatitis. In addition, patients with acute renal failure were found to have a significantly greater average length of stay in the hospital and intensive care units. We move on to complications. Acute fluid collections may occur typically early in the course of acute pancreatitis. These are primarily detected by imaging studies rather than a physical examination. Because they lack a defined wall and usually regress spontaneously, most acute fluid collections require no specific therapy. An acute pseudocyst is a collection of pancreatic fluid that is walled off by granulation tissue after an episode of acute pancreatitis. It requires 4 or more weeks to develop. Although pseudocysts are sometimes palpable on physical examination, They are usually detected with abdominal ultrasonography or computed tomography. Intra-abdominal infection is common. Within the first 1 to 3 weeks, fluid collections or pancreatic necrosis can become infected and jeopardize clinical outcome. From 3 to 6 weeks, pseudocysts may become infected or a pancreatic abscess may develop. A pancreatic abscess is a circumscribed intra-abdominal collection of pus within or in proximity to the pancreas. It is believed to arise from localized necrosis with subsequent liquefaction that becomes infected. The intestinal flora is the predominant source of bacteria causing the infection. The usual suspects are Escherichia coli, Pseudomonas species, Staphylococcus, Klebsiella proteus, Streptococcus, Enterobacter, and anaerobic organisms. Fungal superinfections may occur weeks or months into the course of severe necrotizing pancreatitis. Pancreatic necrosis is a non-viable area of pancreatic parenchyma that is often associated with peripancreatic fat necrosis and is principally diagnosed with the aid of dynamic spiral CT scans. Distinguishing between infected and sterile pancreatic necrosis is an ongoing clinical challenge. Sterile pancreatic necrosis is usually treated with aggressive medical management, whereas almost all patients with infected pancreatic necrosis require surgical debridement or percutaneous drainage if they are to survive. Hemorrhage into gastrointestinal tract, retroperitoneum, or the peritoneal cavity is possible because of erosion of large vessels. Intestinal obstruction or necrosis may occur. Common bile duct obstruction may be caused by a pancreatic abscess, pseudocyst, a biliary stone that caused the pancreatitis. An internal pancreatic fistula from pancreatic duct disruption or a leaking pancreatic pseudocyst may also occur. In weeks or months following presentation, physician's attention shifts to developing signs of intra-abdominal infection, pseudocyst, intra-abdominal hemorrhage, colon perforation, obstruction or fistulization, and multi-organ system failure. Now we move on to prognosis. The overall mortality in patients with acute pancreatitis is about 10%. Patients with biliary pancreatitis tend to have a higher mortality than patients with alcoholic pancreatitis. This rate has been falling over the last 2 decades as improvement in supportive care have been initiated. Type 2 diabetes mellitus has also been associated with higher severity and mortality in the setting of acute pancreatitis. In patients with severe disease, organ failure, who account for about 20% of presentations, mortality is approximately 30%. This figure was not decreased in the past 10 years. In patients with pancreatic necrosis without organ failure, the mortality approaches zero. In the first week of illness, most deaths result from multi-organ system failure. As subsequent weeks, infection plays a more significant role, but organ failure still constitutes a major cause of mortality. Acute respiratory distress syndrome, ARDS, acute renal failure, cardiac depression, hemorrhage, and hypotensive shock all may be systemic manifestations of acute pancreatitis in its most severe form. Identifying patients in the greatest need of aggressive medical treatment by differentiating their disease severity as mild or severe is recommended. In mild disease, the pancreas exhibits intestinal edema and inflammatory infiltrate without hemorrhage or necrosis, and usually minimal or no organ dysfunction. In severe disease, the inflammatory infiltrate is severely associated with the necrosis of the parenchyma, often accompanied by evidence of severe gland dysfunction, and it may be associated with multi-organ system failure. Different strategies have been used to assess the severity of acute pancreatitis and predict outcome. Several clinical scoring systems, for example Ransom criteria, Glasgow, IMRI, are available. The Apache 2 scoring system, though, cumbersome appears to be the best validated. Biological markers also have been used for this purpose. Genetic markers are being studied and have not yet come into clinical use. Peritoneal lavage has a high specificity of 93%, however, it has a low sensitivity of almost 50%. Dynamic CT scanning of the abdomen is widely available and useful in predicting the outcome of acute pancreatitis. When Balthazar criteria are used, sensitivity is 87% and specificity 88%. Now we move on to history. The cardinal symptom of acute pancreatitis is abdominal pain, which is characteristically dull, boring, and steady. Usually the pain is sudden at onset and gradually intensifies in severity until reaching a constant ache. Most often it is located in the upper abdomen, usually in the epigastric region, but it may be perceived more on the left or the right side depending on which portion of pancreas is involved. The pain radiates directly through the abdomen to the back in approximately one half of cases. Nausea and vomiting are often present along with the accompanying anorexia. Diarrhea can also occur. Positioning can be important because the discomfort frequently improves with the patient sitting up or bending forward. However, this improvement is usually temporary. The duration of pain varies but typically lasts more than a day, and it is the intensity and persistence of the pain that usually causes patients to seek medical attention. A patient may tell about recent operative or other invasive procedures, for example, ERCP, or family history of hypertriglyceridemia. Patients frequently have a history of previous biliary colic and binge alcohol consumption, the major causes of acute pancreatitis. Clinical presentation. The most common symptoms and signs include severe epigastric pain or upper abdominal pain, radiating in the back in 50% of cases, nausea, vomiting, loss of appetite, fever, chills, shivering, hemodynamic instability, including shock, tachycardia, respiratory distress, peritonitis, hiccup. Although these are common symptoms, they are not always present. Simple abdominal pain may be the sole symptom. Signs that are less common and indicate severe disease include Gray Turner sign, that's hemorrhagic discoloration of the flanks, Collins sign, hemorrhagic discoloration of umbilicus, pleural effusions, fluid in the basis of a pleural cavity, Grunwald sign, appearance of ecchymosis, large bruise around the umbilicus due to local toxic lesion of the vessels. Curtis sign, pain on resistance in the zone where the head of pancreas is located. That's in epigastrium 6-7 centimeters above the umbilicus. Kamenchik sign, pain with pressure under the xiphoid process. Mayer-Robson sign, pain while pressing at the top of the angle lateral to the rector spinae muscles and below the left 12th rib. And Pandiraja sign, ecchymosis of right axilla. Here in this picture you may see how pain irradiation looks like at acute pancreatitis. Varying on the severity of the disease following physical examination findings may be noted. Fever in 76% of cases and tachycardia are common abnormal vital signs. Hypotension may be noted. Abdominal tenderness, muscular guarding, and distension are observed in most patients. Bowel sounds are often diminished or absent because of gastric and transverse colonic ileus. Guarding tends to be more pronounced in the upper abdomen. A minority of patients experience jaundice, just a little bit more than 28%. Some patients experience dyspnea, which can be caused by irritation of the diaphragm from inflammation and pleural effusion. In severe cases, hemodynamic instability is evident, and hematemesis or melena sometimes develops. Occasionally, in the extremities, muscular sign of the spasm may be noted secondary to hypocalcemia. A few uncommon physical findings are associated with severe necrotizing pancreatitis. The Collins sign is a bluish discoloration around the umbilicus resulting from hemiperitoneum. And Great Turner sign is a reddish-brown discoloration along the flanks resulting from extraperitoneal blood dissecting along tissue planes. More commonly, patients have a ruddy erythema in the flanks secondary to extravasated pancreatic exudate. Erythematous skin nodules may result from local subcutaneous fat necrosis. These are usually not more than 1 cm in size and typically are located on extensor skin surfaces. In addition, polyarthritis is occasionally seen. Rarely, abnormalities of fundoscopic examination may be seen in severe pancreatitis. Termed puncture retinopathy, the ischemic injury to the retina appears to be caused by activation of complement and agglutination of blood cells within the retinal vessels. It may cause temporary or permanent blindness. On the next slide, you may see Collins sign, that's the bruise around umbilicus. This picture is showing the granule sign, that's ecchymosis and large bruise around the umbilicus. Here you can see typical Great Turner signs with ecchymosis on the flanks. And here's the typical left-sided pleural effusion as a complication of acute pancreatitis. So we move on to approach considerations. Once a working diagnosis of acute pancreatitis is reached, laboratory tests are obtained to support the clinical impression. In addition to confirming the diagnosis, lab tests are helpful in determining etiology and looking for complications. Although diagnostic imaging is unnecessary in most cases of pancreatitis, visualization of inflammatory changes within the pancreas provides morphologic confirmation of the diagnosis. Obtain imaging tests when the diagnosis is in doubt, when severe pancreatitis is present, or when a given imaging study might provide specific information needed to answer the clinical question. Image-guided aspiration may be useful for differentiating infected from sterile necrosis and for draining fluid collections. Genetic testing for mutations associated with acute pancreatitis may be considered, even if effective treatment for these genetic conditions is lacking. There are guidelines for the management of acute pancreatitis at the guidelines of American College of Gastroenterology, and they include the following. Because acute pancreatitis can usually be diagnosed based on clinical symptoms and lab tests, contrast enhanced computed tomography or MRI of the pancreas should be performed only in the absence of clinical improvement and when the diagnosis is unclear. Assessment of the patient's hemodynamic status should occur immediately upon presentation with resuscitative measures initiated as necessary. Patients with systemic inflammatory response syndrome and organ failure should, if possible, be admitted to the intensive care units. All patients should receive aggressive hydration unless this is precluded by cardiovascular and renal comorbidities. Aggressive intravenous hydration is most effective with the first 12 up to 24 hours, with possibly little benefit derived from its administration after this point. Within 24 hours of admission, patients with concurrent acute cholangitis should undergo endoscopic retrograde cholangiopancreatography and in high-risk patients, the risk of severe post-RCP pancreatitis should be reduced through the use of post-procedure rectal anti-inflammatory drugs, suppositories, or pancreatic duct stents. The guidelines recommend against routinely using prophylactic antibiotics in cases of severe acute pancreatitis. In mild cases of acute pancreatitis with no nausea, vomiting, oral feeding can be initiated immediately. Enteral nutrition should be used in several cases and in severe cases to prevent infectious complications, and parenteral nutrition should be avoided. Regardless of the lesion size, location, and extension, intervention is not necessary for asymptomatic pancreatic or extrapancreatic necrosis or pseudocysts. Surgical, radiologic, and endoscopic drainage in stable patients with infected necrosis should be postponed for at least 4 weeks if possible, to permit a wall to develop around the necrosis. There is also a guideline for the diagnosis and management of asymptomatic neoplastic pancreatic cysts, and it says that for asymptomatic mucinous cyst, a 2-year interval is recommended for cysts of any size undergoing surveillance, with surveillance being stopped after 5 years if there is no change. Perform surgery only if there is more than one concerning feature on MRI confirmed on endoscopic ultrasonography, and only in the centers with high volumes of pancreatic surgery. The next one is that the risk of malignant transformation of pancreatic cysts is approximately 0.24% per year, and the risk of cancer in cyst without a significant change over a 5-year period is likely to be lower. The small risk of malignant progression in stable cysts is likely overweighted by the cost, surveillance, and risk of surgery. Positive cytology on fine needle aspiration has the highest specificity for diagnosing malignancy. If there is a combination of high-risk features on imaging, that is likely to increase the risk of malignancy ever further. Similarly, if a cyst has both solid component and a dilated pancreatic duct, confirmed on MRI and ultrasound, the specificity for malignancy is likely to be high even in the absence of positive cytology. There is lower intermediate postoperative mortality as well as long-term mortality for patients who undergo surgery in a high-volume pancreatic centers. It seems sensible to screening even after the cyst has been resected, provided the patient has not undergone total pancreatectomy. Surveillance should continue as long as the patient remains a good candidate for surgery. MRI every 2 years may be a reasonable approach for these patients. The clinician may elect to offer more frequent surveillance in the case of invasive cancer resection, particularly if there is concern that the lesion has not been fully resected. Alright, let's move on to laboratory studies. Amylase and lipase. Serum amylase and lipase level are typically elevated in persons with acute pancreatitis. However, these elevations may only indicate pancreatitis. In research studies, amylase or lipase level at least 3 times above the reference range are generally considered diagnostic of acute pancreatitis. Serum amylase determinations are routinely available, but they are not specific for pancreatitis. Preferably, the amylase P level should be measured, which is somewhat more specific to pancreatic pathology. Elevations can occur in patients with small intestinal obstruction, mesenteric ischemia, tuber-ovarian disease, renal insufficiency, or microamylasemia. Rarely, elevations may reflect parotitis. The serum half-life of amylase is short, and elevations generally return to the reference ranges within few days. Lipase has a slightly longer half-life, and its abnormalities may support the diagnosis if a delay occurs between the pain episode and the time the patient seeks medical attention. Elevated lipase levels are more specific to the pancreas than elevated amylase levels. Lipase levels remain high for 12 days. In patients with chronic pancreatitis, usually caused by alcohol abuse, lipase levels may be elevated in the presence of a normal serum amylase level. The level of serum amylase or lipase does not indicate whether the disease is mild, moderate, or severe, and monitoring levels serially during the course of hospitalization does not offer insight into the prognosis. Liver-associated enzymes determining alkaline phosphatase, total bilirubin, AST and ALT levels to search for evidence of gallstone pancreatitis. An ALT level higher than 150 suggests gallstone pancreatitis and a more fulminant disease course. Serum electrolytes, BUN, creatinine, glucose, cholesterol, and triglycerides. Obtain measurements for blood urea nitrogen, creatinine, and electrolytes. A great disturbance in the electrolyte balance is usually found secondary to third spacing of fluids. Measure blood glucose levels because it may be elevated from B-cell injury of the pancreas. Measure calcium, cholesterol, and triglyceride levels to search for an etiology of pancreatitis. For example, hypercalcemia or hypolipidemia, or complications of pancreatitis. For example, hypocalcemia resulting from saponification of fats in the retroperitoneum. However, be aware that baseline serum triglyceride levels can be falsely lowered during an episode of acute pancreatitis. Complete blood count and hematocrit. A complete blood count demonstrates leukocytosis, white blood cell count higher than 12, with the differential being shifted toward the segmented polymorphonuclear cells. Leukocytosis may represent inflammation or infection. Hema concentration at admission, an admission hematocrit value greater than 47%, has been proposed as a sensitive measure for more severe disease. However, this has subsequently been shown to have value only as a negative predictor. That is, a lack of hema concentration effectively rules out severe disease. If blood transfusion is necessary, as in cases of hemorrhagic pancreatitis, obtain type and cross-match. C-reactive protein. CRP value can be obtained 24 to 48 hours after presentation to provide some indication of prognosis. Higher levels have been shown to correlate with the propensity toward organ failure. A CRP value in double figures, for example more than 10, strongly indicates severe pancreatitis. CRP is an acute phase reactant that is not specific for pancreatitis. And the other tests. Evaluate arterial blood gases as a patient is dyspneic. Whether tachypnea is due to acute respiratory distress syndrome or diaphragmatic irritation might be determined. Lactic dehydrogenase, BUN, and bicarbonate levels should be measured both at admission and 48 hours in order to help determine the Ranson criteria for survival. Immunoglobulin G4 levels can be checked to evaluate for autoimmune pancreatitis, especially in recurrent acute pancreatitis that is not explained by an obvious etiology. However, this test is not specific because IgG4 levels can be elevated in as many as 10% of patients with acute pancreatitis who do not have autoimmune pancreatitis. Trypsin and its precursor trypsinogen 2 in both the urine and the peritoneal fluid have been evaluated as possible markers for acute pancreatitis, especially post-ERCP pancreatitis. but are not widely used. Trypsinogen activation peptide is formed when trypsinogen is cleaved to form trypsin and can be measured commercially in the urine to diagnose acute pancreatitis and to help determine severity. Although not currently in use clinically, polymorphism of the hemokine monocyte chemotactic protein gene can also predict severity. Let's move on to digital imaging. Digital imaging will start from abdominal radiography, and abdominal radiographs have a limited role in acute pancreatitis. Kidneys, ureters, bladder radiography with the patient in the upright position is primarily performed to detect free air in the abdomen, indicating a perforated viscus, as would be the case in a penetrating perforated duodenal ulcer. In some cases, the inflammatory process may damage peripancreatic structures, resulting in a colon cut-off sign, a sentinel loop, or an ileus. The presence of calcifications within or around the pancreas may indicate chronic pancreatitis. As for the ultrasonography, abdominal ultrasonography is the most useful initial test in determining the etiology of pancreatitis and is technique of choice for detecting gallstones. In the setting of acute pancreatitis, sensitivity is reduced to 70–80%. In addition, the ability to identify cholelithiasis is limited. Although ultrasonography can be used as a screening test, it may not be specific if overlying gas shadows secondary to bowel distension are present. Ultrasonography cannot measure the severity of the disease. Endoscopic ultrasonography is the endoscopic procedure that allows a high-frequency ultrasound transducer to be inserted into GI tract to visualize the pancreas and the biliary tract. This study allows a more detailed image to be obtained than with transcutaneous ultrasonography because of high-frequency transducer can be introduced directly adjacent to the pancreas. The principal role in the evaluation of acute pancreatitis is the detection of microlithiasis and periampullary lesions not easily revealed by other methods. This modality should be not used to help identify chronic pancreatitis until several months after the episode of acute pancreatitis. In specialized centers with highly trained medical staff, a secretin-stimulated endoscopic ultrasound study may reveal resistance to ductal outflow at the level of papilla, as evidenced by dilatation of the pancreatic duct to a greater extent and longer duration than in a healthy population. This might be helpful in evaluating patients with recurrent idiopathic pancreatitis. Computed tomography scanning. Abdominal CT scanning is generally not indicated for patients with mild pancreatitis unless a pancreatic tumor is suspected, usually in elderly patients. It is always indicated in patients with severe acute pancreatitis and is imaging study of choice for assessing complications. Scans are seldom needed within the first 72 hours after symptom onset unless the diagnosis is uncertain, because inflammatory changes are often not radiologically present until this time. Abdominal CT scans also provide prognostic information based on the following grading score developed by Baltazar and colleagues. Grade A, normal pancreas. Grade B, focal or diffuse gland enlargement. Grade C, intrinsic gland abnormality recognized by haziness on the scan. D, single ill-defined collection of phlegmone. And grade E, two or more ill-defined collections of the presence of gas in or near the pancreas. The chances of infection and death are virtually nil in grades A and B, but steadily increase in grades C through E. Patients with grade E pancreatitis have 50% chance of developing an infection and 15% chance of dying. Dynamic spiral CT scanning is used to determine the presence and extent of pancreatic necrosis. After the administration of an oral agent to define bowel structures, A study of the upper abdomen is performed twice, before and after administration of an intravenous bolus of iodine contrast agent. For a healthy pancreas, density numbers are in the range of 30-40 Hounsfield units on an unenhanced study, increasing to about 150 Hounsfield units on an enhanced study. When pancreatic necrosis is present, focal or diffuse areas of unenhanced parenchyma on the second study suggest pancreatic necrosis. Pancreatic necrosis for research purposes is defined as loss of enhancement in at least 30% of pancreatic parenchyma. Magnetic resonance cholangiopancreatography, MRCP, has an emerging role in the diagnosis of suspected biliary and pancreatic duct obstruction in the setting of pancreatitis. Heavily T2 weighted images provide a non-invasive image of the biliary and pancreatic ducts. Although MRCP is not as sensitive as endoscopic retrograde cholangiopancreatography, it is safer, non-invasive, and fast, as well as provides images useful in guiding clinical care decisions. MRCP should be used in cholelithiasis is suspected, but there is concern that pancreatitis must worsen if ERCP is performed. Endoscopic retrograde cholangiopancreatography. ERCP is an endoscopic procedure used to evaluate the biliary and pancreatic ductal systems and is indicated in a subset of patients with acute pancreatitis. However, ERCP should be used with extreme caution in patients with acute pancreatitis and should never be used in a first-line diagnostic tool in this disease. The procedure should be performed only in the following situations. The patient has severe acute pancreatitis that is believed and is seen on other radiographic studies to be secondary to cholelithiasis. The patient has biliary pancreatitis and is experiencing worsening jaundice and clinical deterioration despite maximal supportive therapy. When combined with sphincterotomy and stone extraction, ERCP may reduce the length of hospital stay, the complication rate, and possibly mortality. In the case of biliary pancreatitis, where a dilated obstructed common bile duct is diagnosed on the basis of the findings of computed tomography, scanning, or any other imaging modality, and an elevated plasma bilirubin level more than 5, ERCP with sphincterotomy is warranted within the first 72 hours. Biliary pancreatitis should always be treated eventually with a cholecystectomy after the process has subsided. Occasionally, ERCP with sphincter of Oddi manometry reveals sphincter of Oddi dysfunction as the cause of recurrent idiopathic pancreatitis. Known risk factors for post-ERCP pancreatitis are any acute pancreatitis or a history of post-ERCP pancreatitis, younger age, female sex, absence of bile duct stones, more than 10 attempts to cannulate the papilla of water, pancreatic duct cannulation, pancreatic sphincterotomy, sphincter of Oddi dysfunction, and contrast medium injection of the pancreatic system. If suspected sphincter of Oddi dysfunction, especially type 3, the risk of procedure-induced pancreatitis can exceed 30%. It is generally thought the experience of the operator is a risk factor for post-ERCP pancreatitis. Although no difference was found between case volume and endoscopist center. Image-guided aspiration and drainage. Computed tomography-guided needle aspiration is used to differentiate infected necrosis from sterile necrosis in patients with severe necrotizing pancreatitis. The needle is placed onto an area of low attenuation in or around the pancreas of a patient with fever and tachycardia or other signs of a systemic inflammatory response syndrome, generally following the first week of severe pancreatitis. The procedure may be repeated weekly if clinically indicated. The specimen should be delivered to the lab within an hour and interpreted promptly. The specimen should always be evaluated for gram stain culture and sincerity. If a gram stain shows bacteria or fungi, surgical debridement of the infected necrosis is generally indicated. An exception would be if the patient cannot tolerate surgery. In that case, CT-guided catheter drainage may be more effective. Endoscopic ultrasonography guided needle aspiration can often be used to differentiate infected necrosis from sterile necrosis in the same manner as CT-guided one. It can also be used to guide drainage to pancreatic and peripancreatic fluid collections that have complicated an episode of acute pancreatitis. These procedures should only be carried out once the pseudocyst has had an opportunity to mature. A complete description of these procedures is beyond the scope of this lecture. And the last one, the last imaging modality, genetic testing. With the advent of molecular medicine, various genetic abnormalities have been identified with pancreatitis. Although effective treatments for these conditions have yet to be discovered, it is sometimes reasonable to begin testing for these mutations in patients with otherwise idiopathic pancreatitis, rather than subjecting the entire group to the risk of endoscopic sphincterotomy or stent placement for a presumptive diagnosis of sphincterofolia dysfunction. As more is learned about molecular mechanism and therapy, logical novel treatments may eventually be offered to this potential as a part of clinical trials. At least 4 mutations have been identified. These mutations appear to render the protein resistant to second-line proteolytic defense mechanisms. Patients with these mutations typically develop their first episode of pancreatitis by the time they are in their mid-teens. More often, there is a strong family history of pancreatic disease, for example, acute or chronic pancreatitis, pancreatic malignancy, and it should be noted that PRSS1 mutation-related pancreatitis is very rare. Some patients have idiopathic pancreatitis with atypical mutations in the CFTR gene, which follows autosomal recessive pattern of inheritance. On this picture, you might see a mild biliary pancreatitis CT scan, where you can see a bit enlarged edematic pancreas and gallstones in the gallbladder. That definitely means and tells us about the nature, about the etiology of this pancreatitis. On this CT scan, you see the necrosis. So on the left side, on the first day, pancreas is edematic, but the contours of the gland are clearly seen. It's just a bit enlarged and a bit changed density. On the day 3, fulminant pancreatic necrosis, you may see that there are no margins of the gland, and there are places of necrosis. Here you can see obstructed bile duct. How can we know that the duct is obstructed? That's pretty easy. These arrows showing you, for example, yellow arrow showing you stone in the common bile duct, and green arrow, for example, showing you the enlarged proximal part of common bile duct. So moving on to moving on to the histological findings. For practical purposes, the infinite spectrum of pancreatitis severity is usually subdivided into mild and severe categories as follows. Mild pancreatitis, the gland exhibits interstitial edema and an inflammatory infiltrate without hemorrhage or necrosis, usually with minimal or no organ dysfunction. Severe pancreatitis is with extensive inflammation and necrosis of pancreatic parenchyma are present, often associated with severe gland dysfunction and multi-organ system failure. At surgery, pancreatic fatty tissue is predominantly involved by necrosis, whereas the gland is usually less affected. Hence, the extent of pancreatic necrosis is commonly overestimated. In very severe cases, arterial thrombosis may lead to panlobular infarction, in which the gland becomes a hemorrhagic, necrotic, gangrenous mass. A natural history of fat necrosis depends on its location and extent. Small areas less than 1 cm may resolve entirely, whereas large areas more than 5 cm may liquefy within the fibrotic capsule. Some words about the staging. Various stages have been used to predict the severity and outcome of acute pancreatitis, including Ranson, acute physiology and chronic health evaluation, that's Apache, 2, Glasgow, the IMER scoring, and each has advantages and disadvantages, and none is currently recognized as the criterion standard. For research purposes, the Atlanta classification of acute pancreatitis has been used to differentiate between severe and mild cases of acute pancreatitis. According to this classification, patients are diagnosed with severe acute pancreatitis if they show the following: evidence of organ failure, for example, systolic blood pressure below 90, arterial partial pressure of oxygen 60 or lower, serum creatinine level of 2 milligrams, GI bleeding amounting up to half a liter or more in 24 hours. Second thing is local complications, for example, necrosis, abscess, pseudocyst. And the third one is Ranson score of 3 or higher, or Apache score of 8 or higher. So probably we'll start from Ranson criteria. And Ranson used a series of different criteria for the severity of acute pancreatitis to formulate a scoring system that is still widely used. Criteria present on admission include the following: patient older than 55 years, white blood cells count higher than 16, blood glucose level higher than 200 milligrams, serum LDH level higher than 350, AST level higher than 250. Criteria developed in first 48 hours include the following: hematocrit fall of more than 10%, BUN level increase by more than 8 milligrams, serum calcium level lower than 8 milligrams, PO2 less than 60 milligram, and base deficit higher than 4 equivalent units. And the last one, estimated fluid sequestration higher than 6 liters. Each of the above criteria counts for 1 point toward the score. A Ranson score of 1 or 2 has a minimal mortality, and the patient is admitted to the regular ward for medical therapy and support. A Ranson score of 3 to 5 has a 10 up to 20 mortality rate, and the patient should be admitted to intensive care unit. If the score is higher than 5, the mortality rate would be about half of the people who are sick and is associated with more systemic complications. Although the Ranson criteria are perhaps the best known scoring system, they have several drawbacks. First, it's because 11 criteria used, some of which are evaluated on day 1 and others on day 2. The Ranson score is valid only at 48 hours after onset and not at any other time during the disease. Second, the threshold for abdominal value depends on whether the pancreatitis is caused by alcohol or gallstones. And finally, the sensitivity is only 73% and the specificity is around that number. BUN level elevated at admission has been associated with an increase in severe acute pancreatitis and death. This corresponds well with the Apache 2 score. The rise of BUN is thought to be due to hemoconcentration, which is a surrogate making for intravascular depletion and which is thought to be a key mediator of inflammatory response at acute pancreatitis. Apache 2 score has the advantage of being able to assess the patient at any point during the illness. However, it is very cumbersome for routine clinical use. Attempts have been made to make this evaluation user-friendly, but it remains cumbersome. The sensitivity is around ransom score. We won't stop on biological markers and genetic markers in this lecture because it's the direction that just develops and has now only theoretical meaning. Alright, we'll go on to approach considerations. Medical management of mild acute pancreatitis is relatively straightforward. The patient is kept nil per os, that's nothing by mouth, and intravenous fluid hydration is provided. Analgesics are administered for pain relief. Antibiotics are generally not indicated. If ultrasonograms show evidence of gallstones and if the cause of pancreatitis is believed to be biliary, a cholecystectomy should be performed during the same hospital admission. Feeding should be introduced anteriorly as the patient's anorexia and pain resolves. Patients can be initiated on a low-fat diet initially and need not invariably start their dietary advancement during a clear liquid diet. Systematic reviews and meta-analysis have shown that the administration of enteral nutrition may reduce mortality and infectious complications compared with parenteral nutrition. Although the ideal timing to initiate enteral feeding remains undetermined, administration within 48 hours appears to be safe and tolerated. Serum amylase and lipase level can be elevated in patients with brain injury. These patients are generally cared for in an intensive care unit and require mechanical ventilation. Pancreatic enzyme elevations may rise and fall considerably over many days to weeks. The elevation is believed to result from hyperstimulation of the pancreas via a central mechanism, but no evidence of acute pancreatitis is present on imaging studies. Patients with severe acute pancreatitis require intensive care, and within hours to days, a number of complications, a shock, pulmonary failure, renal failure, gastrointestinal bleeding, or multi-organ system failure may develop. Goals for medical management are to provide aggressive supportive care, to decrease inflammation, to limit infection or superinfection, and to identify and treat the complications as appropriate. Autoimmune pancreatitis is a rare condition, and corticosteroids should not be used to treat this condition in the short term in patients who are suspected of having autoimmune pancreatitis and who present with acute pancreatitis. No evidence-based guidelines specify when a patient should be transferred to a more experienced or skilled medical center. However, if severe acute pancreatitis is suggested either by Atlanta criteria or by C-reactive protein level above 10, Ransom score 4 or higher, or Apache 2 score 9 or higher, consider transfer to an institution where the intensive staff, the critical care unit, and an interest in subspecialty experience in the diagnosis is available. Further inpatient care depends on whether any of the complications of severe pancreatitis develop and how well patients respond to the treatment. This ranges from few days to several months of intensive care. Patients can be discharged when their pain is well controlled with oral analgesia and they are able to tolerate oral diet that maintains their caloric needs. So the first thing to begin with is supportive care, fluid resuscitation, nutritional support, and so on. Let's start with fluid resuscitation. Patients with acute pancreatitis lose their large amount of fluids to third space into retroperitoneum and intra-abdominal areas. Accordingly, they require prompt intravenous hydration within the first 24 hours. Especially in the early phase of the illness, aggressive fluid resuscitation is critically important. This cannot be overemphasized. There is no universal consensus definitely favoring one type of fluid over another one. Both crystalloids and colloids are used. Resuscitation should be sufficient to maintain hemodynamic stability. This usually involves administration of several liters of fluid as a bolus, followed by continuous infusions at a rate of 250 till 500 milliliters per hour. Central venous pressure, pulmonary artery wedge pressure, and urine output can be followed up as markers of adequate hydration. Careful attention should be paid to signs of overhydration, such as pulmonary edema causing hypoxia. The second thing is nutritional support. General guidelines for nutritional support of patients with acute pancreatitis include the following. In patients with mild complicated pancreatitis, no benefit is observed from nutritional support, and the energy intake received with dextrose in water suffices. Oral feedings should be initiated once the patient's pain and anorexia resolve. In patients with moderate to severe pancreatitis, begin nutritional support early in the course of management, as soon as stabilization of fluid and hemodynamic parameters permits. Optimally, nasojejunal feedings with a low-fat formulation should be initiated at admission. Total parenteral nutrition may be required when patients cannot meet their caloric needs with enteral nutrition or when adequate jejunal access cannot be maintained. The solution should include fat emulsions in amount sufficient to prevent essential fatty acid deficiency. If surgery is required for diagnosis or complications of the disease, place a feeding jejunostomy at the time of the operation. Use a low-fat formula. Begin oral feedings while abdominal pain has resolved and the patient regains appetite. The diet should be low in fat and protein. Theoretical considerations regarding the ability of enterocyte to maintain a barrier against bacterial translocation for nasojejunal feedings, hence the recommendation to attempt initiation nasojejunal feedings at admission in all patients admitted to the intensive care units. Antibiotic therapy. Antibiotics, usually drugs of imipenem class, should be used in any case of pancreatitis complicated by infected pancreatic necrosis. However, they should not be given routinely for fever, especially early in the disease course, because this symptom is almost universally secondary to the inflammatory response and typically does not reflect an infectious process. Several controlled trials have evaluated the role of empiric antibiotics in patients with severe acute necrotizing pancreatitis for infectious prophylaxis. One such trial evaluated the role of imipenem cilastatin initiated at admission to prevent infected pancreatic necrosis. This drug combination penetrates the pancreatic parenchyma and reduces the risk of intra-abdominal infection. It appeared to offer some benefit in preventing infectious complications. Unfortunately, fungal superinfection tends to develop later in the clinical course, although the risk is probably overemphasized. The bottom line is that antibiotic prophylaxis in severe pancreatitis is controversial. At this time, the routine use of antibiotic as prophylactic agent infection in severe acute pancreatitis is not recommended. Medication summary would be that the goal of pharmacotherapy is to relieve pain and minimize complications. Currently, no medications are used to treat acute pancreatitis specifically, and the therapy, that's why, is primarily supportive and involves intravenous fluid hydration, analgesics, antibiotics, and treatment of metabolic complications. So, if we are talking about the groups of antibiotics that are prescribed to patients with acute necrotizing pancreatitis, we should emphasize that antibiotics are used to cover the microorganisms that may grow in biliary pancreatitis and acute necrotizing pancreatitis. The empiric antibiotic regimen is usually based on the premise that enteric anaerobic and aerobic gram-bacillus microorganisms are often the cause of pancreatic infections. Once culture sensitivities are obtained, the antibiotic regimen can be adjusted accordingly. I won't stop much on the different groups. You just must know that most often for necrotizing pancreatitis, I use three groups of antibiotics. That would be imipenem or meropenem. That would be ampicillin. And the third one is ceftriaxone or the fourth grade of cephalosporins plus metronidazole or tinidazole to cover all bacteria that could be involved in the process. As for the analgesics, pain control is essential for quality patient care because it ensures patient comfort, promotes pulmonary toilet, and has sedating properties which are beneficial for patients who have sustained trauma or have painful lesions. Propoxyphene products were withdrawn from the market about 10 years ago, and the withdrawal was based on new data showing QT prolongation and therapeutic doses. I'll just name several medications used as analgesics for treatment of acute pancreatitis. That would be acetaminophen, that would be tramadol, and that would be meperidine. Morphine, you must remember that morphine is not applicable. Meperidine has multiple actions similar to those of morphine. It can produce less constipation, smooth muscle spasm, and depression of cough reflex than similar analgesic doses of morphine, but morphine causes spasm of sphincter of Oddi. That's why it's not used. As for the surgical interventions, surgical intervention, whether by minimally invasive or conventional open technique, is indicated when an anatomical complication amenable to a mechanical solution is present. For example, acute necrotizing pancreatitis in which the necrotic phlegmon is excised to limit a potential site of sepsis, or hemorrhagic pancreatitis in which surgical control of bleeding is warranted. Depending on the situation and local expertise, this may require the talents of an interventional radiologist, endoscopist, or surgeon, individually or in combination. So surgical interventions are usually prescribed at gallstone pancreatitis, pancreatic duct disruption, pseudocyst, if it's purulent, infected pancreatic necrosis, and pancreatic abscess. Gallstone pancreatitis. It is optimal for patients admitted with gallstone pancreatitis to undergo cholecystectomy before discharge rather than being scheduled for a later date as an outpatient. Patients discharged with gallstone pancreatitis without a cholecystectomy are at high risk for recurrent bouts of pancreatitis. Although early laparoscopic cholecystectomy appeared to shorten overall hospitalization, there was no big difference between the result of open, conventional, and laparoscopic um, cholecystectomy. All right. The next thing is pancreatic duct disruption and damage to pancreatic ductal system may allow the pancreatic juice to leak from the gland, and the sudden development of hypocalcemia or a rapid increase of retroperitoneal fluid on CT scan is suggestive of this condition. This condition is initially managed by percutaneous placement of a drainage tube into the fluid collection under the guidance of ultrasonography or CT scan. Um, Occasionally, leaks are associated with downstream stenosis that are also amenable to endoscopic treatment, and refractory cases may warrant surgery. If a persistent leak is present in the tail of the gland, a distal pancreatectomy is preferred. If the leak in this head of the gland, a Whipple procedure is the operation of choice. If we are speaking about pseudocysts, we must remember that pseudocysts that are persisting, generally pancreatic fluid collection persisting more than 4 weeks are referred to as acute pseudocysts. And they lack epithelial layer and not considered root cysts. Most pseudocysts can be followed clinically, however, when they are symptomatic, associated with pain, bleeding, or infection, or are larger than 7 centimeters and are rapidly expanding, in acutely ill patient, intervention is indicated. There are several different therapeutic approaches which are implemented depending on the anatomic relations, on the duration of the natural history of the complications. For example, in selected patients with very large fluid collections, percutaneous aspiration of these fluid cysts is a reasonable approach. It also, some non-communicating pseudocysts may be amenable to transmural enterocystostomy, and technical success require a mature cyst that bulges in the foregut, and the distance from the lumen to the cyst cavity should be less than 1 centimeter. In general, purulent pseudocysts should be drained anyway. In fact, pancreatic necrosis, the clinician cannot rely on clinical findings alone and to differentiate infected and sterile pancreatic necrosis. When clinical signs of infection are present in the setting of necrotizing pancreatitis, CT-guided needle aspiration is indicated, and surgery is recommended when large areas of the pancreas are necrotic and percutaneous CT-guided aspiration demonstrates infection on the basis of a positive gram stain. Antibiotic therapy alone is not sufficient to achieve a cure. Aggressive surgical debridement and drainage are necessary to remove that tissue and clear the infection. Pancreatic abscess is also uh, occur late in the course of pancreatitis, and many of these respond to percutaneous catheter drainage and antibiotics, and those that do not respond require surgical debridement and drainage. And several last words about long-term monitoring. Once the patient is stable enough to be discharged from the hospital, routine clinical follow-up care, typically including physical examination and amylase and lipase assays, is needed to monitor for potential complications of pancreatitis, especially pseudocyst. No evidence-based guidelines have been established for outpatient follow-up care, and generally a reasonable time to see the patient within 7 to 10 days from the date of hospital discharge to evaluate how he or she is doing and to check the signs or symptoms of complications. If the pancreatitis was moderate to severe and was associated with peripancreatic fluid collections, subsequent imaging studies are indicated to determine as a pseudocyst has developed. Thank you for your